Now we will discuss the ECG of a person admitted in the acute intensive care unit. We will see what is the abnormality in the ECG, mainly focus on the rhythm of the ECG. So in this ECG we will be focusing mainly on the rhythm. You can see that there is a P wave here. PR interval is prolonged. Then another P wave and a PR interval. But look at here, you can't see an obvious P wave here. But see this T wave and compare with this T wave. Obviously this T is taller. That would mean that the P is on top of the T wave. So there is a variation in the PR interval. Here P is here. PR interval is different from this and this. And this is the PR interval here, another PR interval, and the PR interval. You can see like that. And you look at the ventricular rate. 1, 2, 3, 4, 5 divisions. 5 divisions means ventricular rate will be around 50 per minute. Then you have to compare the atrial rate. For that you have to see two consecutive P waves. See this P wave and the presumed P wave here. The atrial rate obviously is much higher than the ventricular rate if you compare these two P waves. So naturally there are other P waves which you do not see. This is probably another P wave. So that this will be the PP interval. And here one P wave would have been within the QRS, we are not seeing. Here also it is probably within the QRS. So unless you have a very long recording, you cannot definitely see the P coming out of the QRS in such situations. If you look at this ECG, in this location you might be tempted to think that this is just a first degree AV block. At one look it may look like a first degree AV block. But there are abnormalities here, you can see here. On the ST segment, you don't expect ST segment to be like this, a humped ST segment. Here also it is there. Here the ST segment is flat. So you have to cautiously look for the P waves which are probably not visible on first look. So you can see that in this ECG, ventricular rhythm is regular. Atrial rhythm also apparently regular. Actually you have to measure and see. And atrial rate is higher. This is almost double. Ventricular rate. Only problem here is there is an irregularity here. This RR interval is different from the other RR intervals. Otherwise you could have called it as a complete heart block. But when RR interval is varying, you cannot typically call it as a complete heart block. There could be some conduction occurring intermittently. That's why this RR interval is irregular. The classical 4 criteria for diagnosing complete heart block are regular PP interval, regular RR interval, with RR interval more than the PP interval. That means ventricular rate is lower, and totally varying PR interval. Most of the regions it is like that, but here you can see that this RR interval is shorter than the other RR intervals. This is quite common in the setting of inferior wall infarction because the conduction pattern changes. At one time you may see that there is complete heart block, later you may see it is second degree AV block, and later first degree, and it can oscillate between all the three. And here you can see that there is a deep Q wave here, pathological Q wave. Here also there is a pathological Q wave, and mild ST elevation can be seen here. So with slight ST depression in lead 1 AVL, no significant ST elevation or ST depression in V6. So in this case, the reason for the AV conduction disturbance is inferior wall infarction, as evidenced by the Q waves and mild ST elevation. as well as mild ST depression. So this is in the acute phase itself and not much delayed, as the T waves are not inverted. But not in the hyperacute phase, as the T waves are not tall. Some evolutionary change is probably going to come soon. The tall T waves you expect in hyperacute phase has become almost small T waves. Maybe it will get inverted soon. So it might be in the process of evolution. Another important finding that you are seeing is RSR pattern in V1. Tiny r, s and a slurred secondary R wave, RSR prime pattern in V1 is seen. It's also seen in V2. And there is a corresponding slurred S wave in V6 as well as in lead 1 and AVL. Lateral leads showing slurred S wave, anterior leads showing RSR prime pattern, all suggestive of right bundle branch block. Why I say it's unusual is because you don't expect bundle branch block in inferior wall infarction. So then you have to think of other possibilities. Either this could be pre-existing right bundle branch block, or you could think of multivessel disease. For example, this ST depression in lateral leads could either be due to reciprocal change of the inferior wall infarction, or you could have additional disease in the one of the other vessels. Left anterior descending or left circumflex could be there. So if there is dual blood supply lost, then there is a very possibility, typically left anterior descending, because right bundle will be supplied by the left anterior descending coronary artery. We do not know when a patient presents with acute infarction whether there is pre-existing left anterior descending disease which was earlier there, and this could be the acute occlusion. This territory would have been supplied by collaterals from right coronary, and when right coronary gets occluded, there will be ischemia in this territory also, and ischemia of the right bundle can cause right bundle branch block pattern. But we are not seeing features of acute anterior wall infarction associated with it. That is another thing which you have to look for. But there is no ST segment elevation in anterior leads. But this right bundle branch block is unusual in an acute inferior wall infarction with almost complete heart block. This is an odd finding, which you could explain by associated disease of the LAD, left anterior descending coronary artery, or the another possibility is right bundle branch block can occur in normal individuals also. Some normal individuals do have right bundle branch block without much of structural heart disease. So if this was pre-existing, now when an inferior wall infarction occurs, we will see all these findings together. This patient will require early coronary angiography and angioplasty if possible, depending on the vascular anatomy, and you will probably need a pacemaker support also, temporary pacemaker at least. Some cases, they recover immediately after coronary angioplasty, while some of them have worsening and you will need temporary pacing. So in such case, when you go for coronary angiography, it may be better to put a right ventricular lead through the vein, femoral vein or whichever vein you are planning to access. Usually in acute state, you will only access through the femoral vein. So then instead of radial coronary angiography, you may opt for transfemoral also. That's depending on the operator's choice. So those are the possibilities which you have to be considering in this situation.